Now, I think every physician should at least be aware of what is going on in the world of their patients and be able to, A, converse well with them about these things, B, encourage them towards their health that they're pursuing, and then C, kindly steer them away from perhaps the more ill-informed or downright dangerous advice found online. And, honestly, what better person to come to for this than a physician?
That was Dr. Daren Fomin, who joins Dr. Vincent DeLeo this week to talk about the benefits of a ketogenic diet for dermatologic conditions. This is Dermatology Weekly, the official podcast of MDedge Dermatology, where we bring you the latest dermatology news and peer-to-peer conversations with clinical and research experts in the field. I'm the voice of MDedge podcasts, Nick Andrews. Coming up later, Dr. DeLeo and Dr. Fomin discuss the dermatologic benefits of a ketogenic diet. Don't forget that Derm Weekly comes with robust show notes available wherever notes are found in your listening app. And now, this week in dermatology. LGBTQ plus patients face challenges that may have gone overlooked in the clinic for decades, if not longer. In a paper published in the July 2019 edition of Pediatric Dermatology, Dr. Marcus Booz and his colleagues Dr. Hoa Young and Dr. David Inwards Breland wrote that sexual gender minority patients, or SGM, specific education is underrepresented in medical school and in dermatology professional curricula. Today, we look into a massive knowledge gap and how dermatology is uniquely suited to fill it. Jeff Craven covers dermatology as well as a few other specialties for MDedge. Jeff covered a session about treating SGM patients at the 2020 ODAC Dermatology Aesthetic and Clinical Conference in Orlando. Jeff, welcome to the show.
Nick, thanks for having me.
Yeah, of course. So what's it been like covering these sessions? Because you've covered sessions like this for sexual and gender minority patients for multiple specialties across different platforms. What's the vibe kind of been like, and what's the sense in the room at these meetings?
Yeah, it's been interesting. I mean, every session that I've attended over the past 2 or so years, it's been standing room only, and there are obviously these thought leaders in every specialty that are sort of leading the charge, but everybody just seems ready and willing to learn.
So you were in Orlando reporting on this, and it's such a hot button issue across all of culture right now, but tell me what you learned from the meeting.
What's interesting about LGBT care in general, it's been a focus across a number of meetings. So, for example, the American Academy of Pediatric meeting in 2018 had a focus on caring for transgender youth. The ASBMR meeting in 2019 had a focus on bone health in trans patients. And the ASRM meeting in Philadelphia had a focus on reproductive care for adults and fertility preservation for adolescents.
Dr. Angelo Landriscina is Chief Resident of Dermatology at the George Washington School of Medicine in D.C. He gave the presentation.
So the name of my presentation was Developing New Approaches to Caring for LGBTQ plus Patients. The idea of this talk came to me actually after a number of experiences. The first, just coming through my medical education and seeing how patients from these communities, which I'm a part of, have been characterized in medical education. I had found that, much of what we learned about when it came to sexual and gender minority patients pertains specifically only to men who have sex with men. And in those cases, even those patients were quite often flattened into a few associations.
MSM, or men who have sex with men, does sound like a flattening of just a small portion of patients who are sexual or gender minorities. But what about all the other patients who are also sexual gender minorities?
So the best way to be right in these cases, according to Dr. Landriscina, is to let the patient identify themselves and then sort of follow their lead. We now understand that gender and sexuality are on a spectrum, so the sort of classical definitions are LGBT, lesbian, gay, bisexual, and transgender. But there are some newer terms that clinicians might not be familiar with. So there's queer, and that means not heterosexual or not cisgender. Cisgender is when someone identifies with their gender assigned at birth. Then there's non-binary and gender fluid, which means outside the gender binary, so not exclusively male or female. Another good umbrella term is sexual and gender minority patients. That's a good clinical term that you can use that is very neutral. So some terms to avoid: homosexual, transsexual, referring to pre-op or post-op trans patients. That sort of comes from a time when people pathologized same-sex attraction or misunderstood sexuality.
So with all this understanding or misunderstanding of sexuality, it's clear that even outside of the clinic or outside of medicine, there are ways we can all improve. But how is this specific to dermatology?
There's actually a fairly big knowledge gap in this area. A lot of info is focused on men who have sex with men, sort of without thinking about other risk factors for SGM patients. So, for example, a provider may counsel a cisgender gay man about HIV risk, but studies show that these patients are also at greater risk of skin cancer from using tanning beds as well. So men who have sex with men have an elevated risk for HIV. They should be screened annually, at least, with 3 to 6 months for men who have sex with men who have multiple partners. But you should also think about one-time screening for Hep B and Hep C for these patients. In terms of vaccines, you should think about Hep A, Hep B, HPV, and meningococcal vaccines. For women who have sex with women, it's a little bit different. There are a lot of the same risks: HIV, herpes simplex virus, and HPV. But these patients are less likely to think that they need screening, but they should be screened the same as all women. For trans patients, these patients who are undergoing or have undergone a male to female transition should be cared for the same as patients who are male assigned at birth. Some considerations in patients who have undergone a male to female transition: there are complications from estrogen therapy, so these patients could develop melasma or estatotic eczema. They can have unwanted facial hair or body hair, and if they've used filler injections such as silicone, they can actually develop foreign body granulomas, infection, lymphedema, and scarring. So some considerations for patients who have undergone a female to male transition: you can actually have androgen excess from hormone therapy, which can cause conditions like acne, androgenic alopecia, heat rash, fungal infection. And if these patients participate in chest binding, that can actually cause contact dermatitis. They may also have surgical scars from keloids. And in these patients who have androgenic alopecia, you should watch for use of finasteride because it may block wanted sex characteristics.
Dr. Landriscina was blown away by the response to his presentation in Orlando. It's clear by the response that dermatologists are actively seeking information on how better to treat sexual and gender minority patients. But even with all this momentum, a lack of data exists. So the question now becomes, what do the next 5 years look like?
I think, it's a hard question to answer because there's so many ways that we can improve.
Sure.
But I can tell you what I hope happens.
Yeah, let's do that's. Yeah, I think optimism is a good place to start these days.
So I think that one of the most important reasons why we don't have enough information or enough education around these populations is that research is not being done about these patients in the same way it's done for other patients. So one of the things that I advocated for in my talk was the routine collection of data about sexual orientation and gender identity. I did refer to an article that was published in JAMA Dermatology that came out of Ken Katz's group in San Francisco, where they gave basically like a sample intake form. Now, the purpose of that is twofold. One is that you get that intake form, and before you even get in the room, you know how your patient self-identifies from a gender identity and sexuality standpoint. And that way, a lot of the work is already done for you. But in addition to that, routinely collecting that data allows for the creation of large data sets that we could use to study these populations at that level. So one of my biggest hopes is that we go forward as a field, not just in dermatology, but in all of medicine, and start routinely collecting that data. When it comes to dermatology itself, I would hope that this trend towards more conversation and education around these issues, continues to expand. And I hope that our knowledge continues to expand. And lastly, one of the things that I really hope that we recognize as a field especially when it comes to gender identity and transgender patients, is that we are uniquely positioned to provide life-changing, gender-affirming care for them. There's been a lot of attention paid in the literature to the types of aesthetic services that we could provide, but one of the things that I went into in my presentation was basically the types of interventions that these patients are having for their gender transitions and the potential dermatologic sequelae that come out of them and how we could help manage those. So much in the same way that over the last decade or so, we've had the emergence of this concept of like supportive oncodermatology, helping patients who are undergoing treatment for malignancy by allowing them to, continue their treatments and, ameliorating those side effects. We can also provide supportive gender affirming care to transgender patients that will help them go through their transitions and will ultimately improve their quality of life, decrease their gender dysphoria, and make them happier and healthier people overall.
You can read Jeff's full story about Dr. Landriscina's presentation by clicking the link in the podcast notes. I'd like to thank Jeff Craven for stopping by, and I'd like to thank Dr. Landriscina for agreeing to talk with me. Coming up after the break, Peer-to-Peer with Dr. Vincent DeLeo. It's time now for Peer-to-Peer. Please welcome Dr. Vincent DeLeo.
Today we're talking to Dr. Daren Fomin about the ketogenic diet and dermatology. Dr. Fomin is from Walter Reed National Military Medical Center in Bethesda, Maryland. Thank you for joining us today, Dr. Fomin.
Absolutely, sir. My pleasure. Thank you so much for having me.
So let's get started. You describe the need to inform our readers about caring for patients in the present environment due to increasing patient interest in alternative treatments. This is what engendered your research. Can you share that with our listeners?
Absolutely. So, with the birth of the internet and search engines, PubMed, blogging, social media, etc., our patients have a vast amount of literature and knowledge at their fingertips. Now, whether for better or for worse, sometimes it all depends. But they can personally read the books and studies that we as physicians do as well, and they can see that they have or are headed towards a disease state. Take metabolic syndrome, for example. But they can also see studied ways of altering course to avoid that. Many of our patients are strikingly brilliant and able to apply this to their lives and reap results even without a physician. So, for instance, like diet, sleep hygiene, supplements, physical activity. Now, I think every physician should at least be aware of what is going on in the world of their patients and be able to A, converse well with them about these things, B, encourage them towards their health that they're pursuing, and then C, kindly steer them away from perhaps the more ill-informed or downright dangerous advice found online. Dr. Hanfield, who co-authored this article, is actually certified through the Institute of Functional Medicine. He runs here a functional medicine dermatology clinic, and he can also attest to the fact that many people are seeking ways to not merely battle disease, important as that may be, but to pursue health through many avenues, and dietary optimization, as I call it, included. And I think that this is what it comes down to for the layperson, not merely treating a specific disease, but making yourself overall healthier through lifestyle choices. And, honestly, what better person to come to for this than a physician?
That is a great understanding of what's going on now with our patients, I think, all over. So let's get to your article. Can you briefly outline for us ketosis and the ketogenic diet?
Yeah, absolutely. So in simplest terms, ketosis is the state of producing ketones, which is necessary in the absence of sufficient dietary carbohydrates. And this is all to maintain proper organ function. So this can be due to a couple things: fasting, prolonged aerobic activity, think of marathon runners or such, certain physiologic states like pregnancy or being a newborn, or through something like the ketogenic diet. Essentially, there's a metabolic switch, is kind of how we think of it, in our cells that occurs rapidly in response to primarily hormones, so high glucagon and epinephrine, low insulin, and then adipokine signaling heralded by this low glucose, low glycogen state. When that happens, our body kind of ramps up beta oxidation of fatty acids in the mitochondria and turns the human body into a full-throttle ketone-producing machine in order to keep that Krebs cycle going that we all learned about and loved in med school. And if you can, imagine the human race during a famine without this design, we'd die in a few short days. But because of it, we can thrive without carbohydrates. And so the ketogenic diet kind of capitalizes on this and sort of tricks the body into this low glucose state and gets all that metabolic and cellular benefit without the starvation part of, like famine or fasting. By restricting carbohydrates and then, of course, certain amino acids with a predilection for use in neogenesis like alanine or glutamine, we enter into what is known as nutritional ketosis.
Okay, so let's talk now, and just to begin with, just briefly list the dermatologic conditions that might theoretically respond to a ketogenic diet.
Sure, and at least from our reading, I'm sure there may be more, but from our reading of the literature, we think potential candidates would be acne, hidradenitis suppurativa, autoinflammatory syndromes, definitely diabetic skin diseases, melanoma, and perhaps other skin cancers, psoriasis, morphia, and then after reading this Journal of American Academy of Dermatology's December 2019 issue, obesity-related skin disease as well.
That's amazing. That's pretty much everybody that walks into the office.
Right,
so
exactly.
Let's get started with acne. How might the ketogenic diet benefit patients with acne?
Yeah, so we found a couple of mechanisms. First, there's a well-known inflammatory component of acne vulgaris. And Dr. Lee in the Journal of Investigative Dermatology in 2014 showed that interleukin-1 beta is elevated in the skin of patients with acne. Dr. Hume and his colleagues in Nature Medicine in 2015 showed that beta-hydroxybutyrate, which is the main ketone that we produce in ketogenesis, specifically targets and suppresses something known as the NLRP3 inflammasome. This is actually the activating platform for IL-1 beta. So potentially it can sort of decrease or inhibit that inflammatory response in acneiform skin. As well, there's this hormonal component to acne that we're all familiar with. A great paper by Lauren Cordain and his colleagues back in the Archives of Dermatology discussed how elevated insulin levels equates to elevated IGF-1 or insulin-like growth factor 1 levels and decreased IGF binding protein 3 levels. Now, this causes a great milieu for hyperproliferation of the keratinocytes, seen in acne, particularly at the follicular epithelium. So this IGF-BP3, or binding protein 3, has been shown, at least in mice, to be blockers of that hyperproliferation at the retinoic acid receptors, particularly in sebaceous skin. So essentially all of this taken together, the abnormal follicular proliferation, the increased sebum production, which we also see from insulin's effect on IGF-1 and sex hormone binding globulin, upregulating androgens, all this can decrease kind of acne from a multi-angle approach by stopping that hyperproliferation, decreasing inflammation, and kind of optimizing the androgens so that we're not having a ton of sebum being produced. And ultimately, this is like the trifecta of acne as a disease.
Let's move on then to treating diabetic skin disease and the ketogenic diet.
Yeah, absolutely. So the hallmark of diabetes, as we know, is insulin resistance and hyperinsulinemia, as well as elevated glucose. And all of this wreaks havoc across many organ systems, including the skin. Now, there's a good amount of literature out there already showing that low-carbohydrate or even ketogenic diets are formidable and successful treatments in the disease of what we know as carbohydrate intolerance, so metabolic syndrome, insulin resistance, and type 2 diabetes. And this is due to several known mechanisms, and a few we list in the paper. So less glucose entering the body and less fat deposition as a product of that, less end product glycation, less free radical production, enhanced fat loss and metabolic efficiency, increased insulin sensitivity, and then as well decreased inflammation. So theoretically, this can ameliorate or even prevent things like diabetic peripheral neuropathy, which can lead to ulcers. So there could be a risk reduction of ulcer formation, as well as acanthosis nigricans, the microangiopathy that's rampant in the diabetic population, and also the risk for cutaneous infections, lastly.
And finally, in this list of diseases, well, let us talk then about malignancies, melanoma and others.
Yeah, I'm glad you mentioned that because this is where, at least I personally think things get interesting, mainly because of something called the Warburg Effect. Brief history, Otto von Warburg was a physician or researcher who won the Nobel Prize for Medicine in 1931. And his observation was that cancerous cells produce ATP solely through aerobic glycolysis followed by lactic acid fermentation. That all means that cancerous cells only survive in the presence of glycogen. And of course, extrapolated further, this is the basis for the positron emission tomography scan, or the PET scan, which utilizes fluorodeoxyglucose to highlight highly metabolic tissues, such as cancer. But it should be mentioned that metabolic in this case is specifically speaking about glycogen metabolism. So the astute researcher will say, well, this begs the question then, can we exploit this quirk? Can we feed our normal tissues ketones and, quote-unquote, starve out cancer? I'd be the first to admit that current literature isn't definitive by any means, but men like Dr. Thomas Seyfried over at Boston College, Dominic D'Agostino, University of Southern Florida, and Jeff Volek at The Ohio State University, as well as numerous others, have published an increasing amount of literature showing that there is serious potential to exploit this quirk. So much so that even NASA and the Department of Defense have pegged Dr. D'Agostino to work on some of their projects. I think they're onto something, and honestly, it's my hope and kind of my optimistic thought that in 10 to 20 years, maybe we'll see an increasing number of patients being put on some sort of either endogenous or exogenous ketone therapy as an adjunct to their cancer treatments. A number of encouraging case reports are out there, primarily in brain cancers, and I think this is probably because many of them have sort of dim prognoses at the time of diagnosis, but these patients have vastly outlived their given prognosis, halted growth, or even in some cases reverse tumor growth. The latest case I saw was out of Hungary, I think just this past month, where a patient who had glioblastoma completely halted his tumor growth using only what they called in the literature a Paleolithic ketogenic diet. And so far seems to be stable a few years into his disease and going about his life just fine. I'd be curious to see if we can start adding this on to adjunctive melanoma therapy and see if there's an improved outcome in our patients. And then there was one paper we found, I'll briefly mention, that ketones can exert a favorable effect on mTOR, mammalian target of rapamycin, by suppressing it. Obviously, to the magnitude or how to quantify this, we're still unsure, but it has been shown that suppressing mTOR activity does limit and slow tumor growth and spread, and perhaps this could be another useful mechanism with this therapy.
That is an amazing listing of the way that ketosis and the ketogenic diet might actually assist in the treatment of our patients. So there are listeners today who might want to try this, but no treatment has simply no side effects. So what are some of the adverse effects of the ketogenic diet that our listeners should be aware of?
Yeah, that's a very prudent and great point, sir. Generally, overall, it's well tolerated. What we do know is that a couple things like dehydration, so glucose and particularly glycogen, once it's stored in the muscle, provides ample water retention, so dehydration can be an acute issue, although that can be managed. Acidosis is an issue, particularly if you have impaired insulin responses, as seen in advanced diabetes or advanced alcoholism. Lethargy is well known. It's kind of dubbed the Keto Flu. It's thought to be the lag between burning primarily glucose, so glycolysis and gluconeogenesis, and then kind of quote-unquote fat adapting to ketosis at the mitochondrial level. Obviously, this will happen. Some people can seemingly do it overnight. Some people it takes a while, but this will eventually resolve. There's hypoglycemia, which is not necessarily the goal, but a known side effect, as well as the potential for dyslipidemia. But whether this is an atherogenic profile or not is currently being debated and studied. Prurigo pigmentosa, if you've been reading the JAD, has had a few case reports over the last year or two of people adopting a ketogenic state or ketogenic diet and coming up with this kind of pruritic rash, as well as gastrointestinal distress. Now, all of these are transient that we know of so far and can be managed well. Chronic adverse effects could be nephrolithiasis, but there actually are recommended screening procedures for those at risk, as well as prophylactic therapies. And then I put on weight loss as a potential adverse effect, but I think that's probably a small population of people that would think that's an adverse effect, namely people that need to maintain a certain weight, like fighters or football players or something.
So with that in mind, what recommendations can dermatologists offer their patients to ensure the ketogenic diet is implemented safely?
Yeah, that's a great question. I think that, first off, if there is a physician out there that has an interest in prescribing and monitoring these dietary therapies, then educating yourself as the patient's doctor as much as possible, that's step one. The Journal of the American College of Nutrition has many resources, and the American Nutrition Association actually has avenues of certification for physicians in a certified nutrition specialist, including a ketogenic diet specialty. So the more that you know, the more you can help your patients. As far as counseling or initiating the diet, I think having a number of solid resources to point the patient to is very helpful so that the patients can educate themselves. This approach really takes a lot of self-motivation and work by the patient. I have a few resources I use with my patients. I'm happy to share those, either in some show link or via email, which you can find on the paper in Cutis. And then making sure that they know to expect a few days to weeks of potentially noticeable physiologic effects, so hypoglycemia, lethargy, etc., before they become adapted. As far as keeping it safe, simple screening against things like severe dyslipidemia, risk factors for nephrolithiasis and gout, making sure the patient's motivated enough to commit. These are great things to consider. And you can involve educated nutritionists if you have them, if you have access to them.
This has been an incredible discussion of the possibility of using an alternative method like ketogenic diet and ketosis for the treatment, adjunctive treatment, of many skin diseases. Finally, though, you point out the lack of data in this field. What do you think needs to be done in this area of research in the future?
Yeah, I think a couple things. First and foremost, I think physician education is of utmost importance. Back in my day of medical school, which honestly wasn't too long ago, the ketogenic diet was synonymous with ketoacidosis and atherosclerosis. But the literature has actually shown the exact opposite. And so we need to shatter that stigma and dogma based on what the literature is showing us. Next, just like any other potential therapy, the best way to study this and see it as a potential therapy is multi-center, large population, double-blind, randomized control trials. Thankfully, these are actually being done, and a few are being done through Boston Children's Hospital, Harvard, NIH, Stanford, amongst others. And you can actually read about the studies. It's this place called the Nutrition Science Initiative, NUSI, N-U-S-I. They have those studies that they're helping fund listed there, and the potential outcomes and kind of potential release dates of that study.
So, Daren, anything you'd like to add to this discussion? It's been a really enlightening interchange with you. So any final comments for our listeners?
First, just thanks for having me. I'm glad someone else besides me is interested in this topic. I thought I was the only one out there. But secondly, our patients are becoming more and more involved in their own care, and I think that is a benefit of modern medicine as we continue to evolve as a profession. And I think not only things like the ketogenic diet, but just getting into your patient's world, understanding what they are capable of doing for themselves, how you can come alongside them in their journey to health is all very valuable. This is just one way. There are many ways, but coming alongside them as more than just a diagnoser and treater of disease, but promoter of health, I think that's very valuable, and I honestly think that's where medicine is moving more towards.
Well, Daren, thank you so much for joining us today, and I know our listeners are going to go to the journal and get more information from your article. And we want to tell you that we're very thankful that you could join us.
Sir, it's been an absolute pleasure. Thank you so much for having me.
And that's a wrap on the 50th episode of Dermatology Weekly. We launched this podcast a little under a year ago, and we are overwhelmed by the response. We'd like to thank each and every one of you for joining us at any stage of this journey. It's time now to give credit where credit is due. Dermatology Weekly is produced by Elizabeth Meshkati and Melissa Sears. Peer to Peer is hosted and produced by Dr. Vincent DeLeo. Our guests this week were Jeff Craven and Dr. Angelo Landriscina. All of our podcasts at MDedge are produced by our editor-in-chief, Dr. Ivan Oransky, as well as executive editors Kathy Skarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Dermatology Weekly is produced by Tyler Munneck. Social media is produced by Kyla Clark. I'm your audio engineer, audio editor, and the voice of MDedge podcasts, Nick Andrews. You're listening to Dermatology Weekly.